بالhypertension. So hypertension, it's a very important topic. It has a big disease burden. رح احكي انا two lectures. اليوم رح نحكي عن ال beginning او ال most basics part of the hypertension. شو ال definition, how do we treat management wise. بعدين بكره نحكي عن ال hypertensive crisis و resistant hypertension. طيب هلا خليني اسالكم هذا السؤال. How do you define hypertension? What is the number beyond which I will call this is hypertension? 140 systolic و 90. طيب who says yes that's the number? Who disagrees with it? Okay, في ناس disagree. احكي لي شو الرقم؟ 150 over 90. Okay. 130 over 90. Okay. في guidelines مختلفة حسب الدولة. That is correct. Okay. So, yes, there is multiple definitions و multiple cutoffs that are dependent on two things. Number one, على guideline, a resource that you're looking at. Second, how is your patient? How risky is your patient? So a blood pressure of 140 over 90, I might accept on a younger patient, بينما it's definitely way too high for a patient who has diabetes or coronary artery disease. فإذن risk factor. هلا الشغلة الثانية ال different definitions with different institutions. فمثلا لاحظوا كل الأرقام اللي حكيتوها pretty much موجودة. 140 على 90, 150 هيها 130 على 80 وفي حتى كمان as low as 120 مش طالعة هون رح تطلع بعد شوي. هاي مثلا الامريكان كوليدج اوف كارديولوجي واليوروبيان. لاحظوا انه في فرق. هلا to make it easier on you so you've confused us rather than helped us. To make it easier for you في ارقام واضحة pretty much straightforward. 140 على 90 and above الكل متفق this is hypertension. ما في حدا بيقول لك لا. Okay, so 140 ل 90 and above. 150 على 90 only one guideline GNC8 considered it above 65 to be the cutoff. بس هذاك was a bit too lenient. ف I wouldn't bother with it. 140 على 90 and above is definitely hypertensive. هلا الجراي زون ما بين ال 130 لل 140 وما بين 80 لل 90 بالامريكان و85 لل 90 باليوروبيان. Let's make it simple 80 ل 90. هذه الجراي زون اختلفت التسميات إلها. في ناس سموها بري هايبرتنسيف، في ناس سموها ستيج 1 هايبرتنسيف، في ناس سموها شو اسمه border line hypertension. Anyways, it is not completely normal بس depending على الريسك تبع البيشنت تبعي. If he's high risk I'm going to consider it worrisome and treat. If he's lower risk I'm going to do lifestyle only. So overall if you think of it this way you're pretty much in the clear. Okay? هلا it's an easier way to think. So why is hypertension important? This is what I want you to see. So if you notice على what we called borderline hypertension 135 على 85 but in most of the newer guidelines now we'll call it stage 1 hypertension. You already increased the risk by 2 for cardiovascular death. If you get to above 140 over 90 it's 4-fold, and if you get to the severe hypertension above 160 over 100 it's 8-fold. So that's a huge increased risk for an increase in blood pressure. برضو you can see that even from a minor difference, if you drop the blood pressure by 5 millimeters, you're going to decrease the stroke mortality by 14%, all-cause mortality by 7%. If you decrease only by 2 millimeters, you could decrease the ischemic heart disease mortality by 7%. So you can see that a minimal decrease can make a huge difference. Or if you treat it, regardless of the disorder, heart failure or CVA, it's going to make a difference. It's going to improve your survival. So treatment works. So that's why. So first of all, higher blood pressure means worse mortality and worse morbidity. Treating it means yes, you are going to get better. ثالثا الكونسبت التالي، المشكلة بالبلد بريشر بالهايبرتنشن multiple folds. Number one, a lot of people don't know that they're hypertensive. Silent killer, right? Actually, in one of the studies, جمعوا 17 countries, people who were aware of their high blood pressure were only 46%. Majority كانوا ما يعرفوا إنه they didn't know that they had hypertension. Out of those people who are aware, 41 were on medications, 41%. Out of the people who were medicated, 15 or 13% were actually at goal. So it can show you that we're way too far from what we need to be في multiple levels. أول شيء diagnosis, بعدين taking medicines, بعدين actually reaching goal. So this makes hypertension treatment a challenge. With hypertension treatment not only does improve heart, also improves the kidneys, or protects the kidneys. So the first step in diagnosing hypertension is actually measuring blood pressure properly. So how would you measure blood pressure properly? مين بيقدر يحكي لي what is the proper way of measuring blood pressure? يلا مين في عنا؟ Yes, go ahead. تحكي بطلت يا كنتي رافع ايدك ولا بطلت؟ اوكي. اوكي. يس لازم تكون على مستوى القلب بس برضه ريستد يعني مش تكون بالهواء.
ما يكون المريض
صح لازم يكون مرتاح له 5 دقائق ومش شارب ولا ماكل ولا بالضبط.
لازم اتاكد انها قياس مناسب لقياس الجديد.
مظبوط.
اتاكد انه القياسات للادلت غير القياسات للبيدياتريكس ولازم تحط تقريبا 3/4
برافو برافو. تمام صح. Good job. Good job. So in short بالنسبة للسايز لازم يكون الارم circumference بالنسبة للبلادر اللي هي الانفليتابل بارت جوا الكف لازم تكون 80% of your arm circumference والwidth تبعها يكون 40%. وزي ما هي حكت what we do we have sizes فاحنا عندنا small او البيدياتريك size بعدين في عندنا الافريج normal size بعدين في عندنا large obese patients kind of size. So we need to take this in consideration when we're measuring blood pressure. We don't rely on one blood pressure measurements, بس أهم شيء تتذكروا لل 5 R's. So they have to rest for at least 5 minutes before. They have to refrain from eating, drinking, talking while you're doing it, or take the clothes off. ما بتقيس بالضغط والأواعي in place. بعدين you rest both الarm والرست الليجز ما بيصير يكونوا crossed ولا بيكونوا up in the air لازم يكونوا uncrossed وعلى الارض. This is how we take a good blood pressure measurement. هلا عندنا 3 انواع من blood pressure measurements. في عندنا blood pressure measurements بالكلينيك، عندنا blood pressure measurement at home، وعندنا الامبولاتوري blood pressure. هلا الكلينيك ميزتها انه يوجوالي الاجهزه تبعت الكلينيك دقيقه، ويوجوالي البيرسون who takes the blood pressure at clinic takes it in the right way. مشكلتها انه البيشنت is stressed, it's not his usual environment، ممكن يكون جاي مستعجل زهق من الانتظار فالبلد بريشر بيكون اعلى من الطبيعي. الهوم blood pressure measurements are more in reality close to what he's usually used to، بس ممكن طريقة القياس ما تكون دقيقة أو الجهاز ما يكون دقيق. آخر واحدة الامبولاتوري blood pressure monitor، it's a device that you wear، تكون متصل بجهاز على الخاصرة، و takes blood pressure every 15 to 20 minutes, sometimes every 30 minutes. all over 24 hours بعدين بيسلمه. هذا الجهاز دقيق at home يعني has kind of both of realm of both two بس مشكلته انه مزعج. You can imagine if you have a device that every 15 minutes is going to go up, start measuring your blood pressure وينزل خصوصا لما تكون نايم. So sometimes برضه هذا الديفايس is not as comfortable or as reliable. هلا what you do need to know إنه القراءات برضه راح تكون مختلفة. هلا كنا اتفقنا 140 على 90 و above is hypertension صح؟ regardless of التسمية regardless of ال resource. هلا بالهوم لانه اريح المنطقه we drop 5 ملم لهذا الرقم، فاي شيء above 135 over 85 is considered hypertensive. بالambulatory 24 hour which includes nighttime measurements should be 10 ملم mercury lower 130 على 80 وعليه بتقيس الاذر تايبس. اوكي هلا برضه في عندنا تو كونسبتس لازم نفهمهم، واحد اسمه الوايت كوت هايبرتنشن والسكند ماسكد هايبرتنشن. مين بده يحكي لي شو الوايت كوت هايبرتنشن؟ جو هيد. الستريس بيرفع له ضغطه صح. So his blood pressure is high in the clinic, normal at home. صح؟ هذا بنسميه وايت كوت هايبرتنشن. طيب is it good or bad? Or doesn't mean anything?
It does mean something لأنه بالآخر الدكتور ما رح يقدر يعرف الحقيقة.
So actually it is not horrible but it does mean anything. It's a little bit increased risk. وممكن يكون potential marker انه down the road he might become hypertensive. بس كمان برضه اذا بدي احاول احدد في شيء بدور عليه، عشان اذا بدي اعرف فعلا هذا الهايبرتنشن اللي انا شايفه بالعياده فقط عندي بالعياده ولا موجود برضه بالبيت، شو ممكن اعمل؟ بطلب منه يعمل هوم بلاد بريشر مونيتورز او يعمل امبيلاتوري بلاد بريشر مونيتور، او كمان شغله لازم ادور عليها اشوف اذا موجوده ولا لا، لان اذا موجوده it is more consistent that this hypertension is true. اوكي خليكم فكروا فيها. There's something that I need to look for. اوكي طيب شو الماسكد هايبرتنشن؟ هايبرتنشن من غير اعراض كيف يعني؟ كل الهايبرتنشن من غير اعراض. شو؟ هذا كل الهايبرتنشن هيك. ماسكد هايبرتنشن is الأوبوزيت اوف الوايت كوت هايبرتنشن. بكون بالكلينيك نورمال وفي البيت اب نورمال. اوكي سو في الكلينيك نورمال بلود بريشرز، بس في البيت هاي بلود بريشر مونيتورز او الامبلاتوري اب نورمال. طيب هاو ام اي جوينج تو بيك اب هذا المريض؟ يعني سهل المريض اللي بيجيني هايبرتنسيف بالعياده بشوف ضغطه عالي، لكن المريض العكس كيف بدي انا اشك انه هذا ضغطه عالي في البيت وعنده ماسكد هايبرتنشن؟ ثانك يو. So this is what I'm looking for. End organ damage. وهذا هو الشيء الثاني اللي بدور عليه برضه بالوايت كوت هايبرتنشن، لان اذا عندي وايت كوت هايبرتنشن واند اورجان دامج that is more consistent that this is true hypertension. اوكي بينما اذا ما عنده ولا ايفيدنس بكون لا. نعم
احنا نستنى المريض يصير عنده end organ damage عشان نميز.
لا انا بحكي على الوايت كوت هايبرتنشن، احنا we don't want to wait for end organ damage. خليني ارجع.
Consider that it's hypertension even if it was white coat.
Yes. إذا عندي إجاني مريض end organ damage وعنده white coat hypertension, I'm highly suspecting that this is actually going to be true hypertension. وراح أحط ambulatory blood pressure monitor و I'm going to try to fetch and make sure he's not hypertensive. لأن ال white coat, if it's truly white coat, you should not have target organ damage. أوكي؟ هلا الماسك hypertension ألعن لأنه عندي بالعيادة normal بس بالبيت high. ف one of the reasons to make me suspect هذا الحكي شو بعمل؟ بشوف اذا عنده مثلا اجاني مريض عنده تارجت اورجان دامج بس البلاد بريشرز نورمال، طب ليش عنده تارجت اورجان دامج؟ فانا I'm going to suspect, so I'm going to ask him to monitor his blood pressure at home or I'll do an ambulatory blood pressure. So this is when I would suspect it. Okay, well, this is what we're talking about. So normal blood pressure is normal in both. Sustained hypertension is abnormal in both. White coat is high in the office, normal at home. Masked is high at home, normal in the office. Okay, same thing. هلا, target organ damage. It's a very important thing to look for in patients who have hypertension. لأنه أولاً بكشف لي أشياء ثانية. ثانياً, the more our target organ damage, the more aggressive I need to be checking it. So, شو هم target organ damage? Number one, heart disease اللي هو left ventricular hypertrophy, AFib, ischemic heart disease, heart failure, كل هذا symptom of target organ damage. هذا نفسه إذا صار بالperipheral arteries برضه target organ damage vasculopathy. إذا صار بالبرين أو صار عندي encephalopathy بالبرين that's target organ damage. زي ما بيقولوا the eyes are the windows to the soul, the eyes are also the windows to the brain. So if you have retinopathy, that indicates إنه في عندك high blood pressure and you should it's an end organ damage. واخر واحده اللي هي النفروباثي هي الكدنيز. Kidneys في two types of damage that can happen من الهايبرتنشن. One is loss of kidney function. Second, proteinuria او المايكرو البومين. اوكي سو هدول هم target organ damage. بالنسبه للهايبرتنشن الفيرست ستيج بيكون عندي فيزو كونستريكشن فبكون في عندي ثينينج بالارتريز. بعدين بصير في عندي النيكينج هدول اللي هو على الكروسنج بستيج 2. بعدين بستيج 3 بصير في عندي الهارد اكسوديتس والفليم هيموريجز هذا عباره عن مور ادفانس ستيج. بس ultimately لما يصير عندي بابيليديما هي الفورث ستيج which is considered malignant hypertension. It's a hypertension emergency. Hypertension emergency. Okay? هلا what is the primary workup that I need to do to all patients who have hypertension? الفكرة بالprimary workup for hypertension بدي أدور على 3 أشياء. Number 1 بدي أشوف إذا في عندهم target organ damage. Number 2 بدي أشوف هل في risk factors other than hypertension. ليش؟ لأنه بتتذكروا لما حكينا على الأرقام حكينا 140 على 90 أكيد بدي أعالجه، 130 ل 140 80 ل 90 هاي المنطقة. If they're high risk I'm going to treat. So كيف بدي determine high risk? I'm going to look for risk factors. أوكي؟ ثالث شيء بدي أشوف هل في major secondary cause القطة. So this is what I'm looking for in these tests. So fasting blood sugar, I'm looking for diabetes to see risk factor. CBC is just a test that we do for pretty much everyone to look at his status in general. Lipid profile, I'm looking for cholesterol. Serum creatinine, this is 2. أول شيء renal disorders, renal parenchymal disease can cause hypertension, or hypertension can cause kidney problems. So that's why I'm checking his kidneys. Serum sodium electrolytes potassium very important لأنه again hyperaldosteronism is going to cause hypokalemia. Hyperparathyroidism is going to cause calcium disorders. فهدول I'm going to check them. TSH لأنه both hypo or hyperthyroidism are going to cause hypertension. Urine analysis again حكينا one of the target organ damage is microalbumin أو proteinuria, so I need to check for that. ECG, I'm looking for again secondary target organ damage, left ventricular hypertrophy وإسكيميا. So لو تلاحظوا why am I ordering all these tests? I'm looking for either target organ damage أو potential general screen for secondary cause أو other risk factors that might make the treatment تبع my patient أهم or I need to be more aggressive فيه. Alright, هلا طيب السؤال الثاني when would I suspect secondary hypertension and I'm gonna need to look for it specifically. شو هم الريد flags؟ شو هالأشياء اللي إذا أنا شفتها secondary hypertension I need to look for it. So مين بيقدر يحكي لي؟ Yes? Young patient بالضبط لأنه young patient حتى بالessential hypertension is less likely for them to develop especially تحت عمر 30. Number 1. True. رح ارجع لهاي النقطة، أنا بس عشان أخليكم متذكرين السيستم. Young patient والother extreme patient مش hypertensive بعدين على عمر 70 صار عنده hypertension. و not only that الهايبرتنشن تبعه مش systolic لأنه أمرار there is an entity called isolated systolic hypertension which happens in elderly due to the stiffening of the arteries. السيستوليك بيطلع. بس إذا طلع برضه الدياستوليك على هذا العمر so elevated diastolic blood pressure beyond 65 is another marker. So extremes of age. أو إنه يكون مستقر blood pressure and suddenly it changes. Changes either becomes accelerated وmalignant أو he can controlled وبصير مش controlled أو عنده صار resistant hypertension. then I'm going to check for them. So young, age, elderly, resistant hypertension, accelerated malignant hypertension, severe hypertension, or a change in hypertension at a stable patient with stable blood pressure. بالإضافة إلى what you just mentioned, specific scenarios. مثلا يكون hypertension with hypokalemia. Okay, I'm going to suspect like a secondary cause. هدول هم red flags. When I see them, I need to look for a secondary cause. هلا مين بيقدر يحكي لي شو هم secondary causes of hypertension? Yes. Cushing syndrome. Come on. Pheochromocytoma. Renal disease. Renal disease في two types. في renal parenchymal disease وفي renal vascular disorders, renal artery stenosis. Addison. So overall, if I want to think of them, I'll categorize them into three major ones: renal disorders, اللي هم renal parenchymal disease, renal vascular disorders, أو hormonal disorders, hyperthyroidism, hypothyroidism, parathyroid ممكن, Cushing's disease, pheochromocytoma, yes. وهدول الثالث نوع اللي هم structural problem like coarctation of aorta. Okay, so renal, hormonal, coarctation structural problems. مثل adult polycystic kidney disease كمان, بس هذيك برضه تحطوها جزء من الرينال parenchymal. So secondary hypertension is that. One of the important reasons, two things for secondary hypertension that I should always think of is obstructive sleep apnea ودrugs. هدول لا تنسوهم. Sleep apnea, especially if he's a larger person, if he has snoring, it can be a reason for hypertension or resistant hypertension. والنقطة الثانية اللي هي عبارة عن الدراجز. هلا رح نيجي للدراجز a little bit in a minute. طيب, points that are important to remember about each one. Renal parenchymal disease could be glomerulonephritis. عادة بعمل urine analysis, ممكن أشوف hematuria, ممكن أشوف casts, ممكن يكون في عندي kidney dysfunction, ممكن يكون adult polycystic disease. One of the investigations they're going to do is renal ultrasound. Renovascular disorder في منه two types. في atherosclerotic وfibromuscular. Atherosclerotic renovascular disorder or renal artery stenosis happens at elderly stage, usually men, وعندهم atherosclerosis, smoking, hypertension, dyslipidemia, الأشياء اللي بتعرفوها. Another type, fibromuscular, عادة بالyoung women. فإذا إجاني patient hypertensive وyoung female, think of renovascular disorders. وبرضه renovascular أو renal artery stenosis, especially as a bilateral, they will get worse, especially kidney function, with ACE inhibitors. Okay? بالإضافة إلى أنهم أمرار ممكن يدخلوا بشيء بنسميه flash pulmonary edema. تعرف شو يعني flash pulmonary edema? This is a sudden onset of pulmonary edema and they get flooded or short of breath all of a sudden. بيكونوا كل شيء طبيعي فجأة بدخلوا فيها. So think of renovascular stenosis or renal artery stenosis. Yes?
Do psychiatric disorders cause hypertension?
It can be a reason for elevated blood pressure, especially anxiety with stress, but this is the diagnosis of exclusion. Okay. هلا primary aldosteronism, عادة الشيء اللي بيخليني أفكر بالprimary aldosteronism is hypokalemia. Okay. Obstructive sleep apnea حكينا عنها والدراجز رح نحكي عنها in a minute. Pheochromocytoma usually episodic, usually associated with palpitations وبكون sky high. Cushing's بيجوا مع Cushing syndrome والsymptoms تبعتها. Coarctation بكون في radiofemoral delay usually in younger patients, ممكن يكون associated مع bicuspid valve وبكون في هم بالهون due to the collaterals. Okay. هلا medications. Medicine is one of the important causes for hypertension أو resistant hypertension أو accelerated hypertension بالelderly وباليونج وبكلهم. وتذكروا هاي الأشياء. Number one, alcohol طبعا. Amphetamines ممكن amphetamines is becoming unfortunately a bit more frequent في بلادنا. الكابتاغون يعتبر واحد من الأمفيتامين فدير بالكم منه. الكافيين which comes not only as tea or coffee, it comes also as pills. ممكن يجي pills هذول سيئين جدا. ممكن يجوا as energy drinks. ممكن يجوا as supplements. ممكن يجوا as also sodas. So هذول بدكم تدير بالكم منهم. Decongestants, a lot of people take anti-allergy or anti-flu medications or حتى Panda والباراسيتامول, but they don't realize some of these formulations have decongestants in them and they can raise the blood pressure. Oral contraceptives in females can also be a reason. Immunosuppressants, especially cyclosporin. So, why is it important? لأنه cyclosporin is a common immunosuppressant for which patients? Renal transplant. And those patients, you really do not want to hurt the new kidney with high blood pressure. So you need to be careful that it can cause it and you need to follow that up. Non-steroidals, a very frequent and very important cause for high blood pressure. بيكون عنده مثلا knee problem بياخذ له كورس non-steroidal تصير ال blood pressure sky high. نفس الشيء برضه steroids that we can use sometimes as an anti-inflammatory or anti-rheumatological medication can raise your blood pressure or raise blood sugars. Or of course drugs always such as cocaine. هلا بدكم تدير بالكم الكوكاين not to use بيجوا امراض مع tachycardia وبيجوا مع chest pains, so you want to avoid using شو pure beta blockers لانه اذا بتعطيه pure beta blockers بصير عنده unopposed alpha activity ممكن يصير عنده زياده بالبلد pressure, so you want to use a medication that has both alpha and beta activity. Alright, so how do we treat hypertension? أول شيء حكينا نعرف الجول وين شو الرقم تبعنا اللي beyond which إحنا بنعتبره hypertensive. This is what we all agreed upon. 140 على 90 وطالع, this is definitely hypertension. I need to start him on a medication. 130 ل 140 80 ل 90 إذا الريسك تبعه عالي diabetic kidney insufficiency I calculated the score تبعه أعلى من 10%. This one I'm going to treat with medicine. إذا الريسك تبعه low, lifestyle modification. Otherwise, I'm going to follow up and continue treating him. طيب. هلا بعد هيك بيجي I need to recognize the challenges اللي حكينا عنها. في عندنا واحد اسمه resistant hypertension, ممكن يكون mask, ممكن يكون white coat, ممكن يكون medication. So I need to evaluate these things to take them out of the formula. بعد هيك I'll treat them as we're going to discuss in a few minutes. ولooking at the co-morbidities عشان اختار المedication that best suits him. Ultimately, I'm never treating him in one point of time. مش خلص أنا أعطيته كورس علاج وخلص انتهى. No, he's going to need to follow along with me and make sure that he continues to get better or controlled accordingly. هاي شو lifestyle non-pharmacological, weight loss, low sodium diet, increased potassium, exercise, physical activities, decrease in alcohol, decrease in nicotine وهاي الأشياء. هون بدي أحكي عن concept مهم. كثير من المرضى أمرار are concerned that أنا دكتور ما بدي أبلش دواء الضغط عشان ما أتعود عليه. That's a misconception. أول شيء في شيء اسمه متعود على دواء الضغط. What happens is you have a certain state of your body that makes you now need blood pressure medicine. So if you start the blood pressure medications راح يكون go down the road في 3 paths. Path number 1, you're staying the same, so you're going to continue to need the medicine. وإذا وقفته راح ترجع للستاتس اللي قبليها ويطلع ضغطك. Path number 2, you don't take care of yourself, you're still having a lot of other things, you're gaining weight, you're getting older, you're فالبلد pressure راح يطلع. So now you're going to need more medicine to control the disease. مش انك تعودت على الدواء، مش انه بطل يشتغل الدواء او resistant. Your body got worse. So now you need more medicine because you did not take care of yourself. But a third possibility is if you change the status quo, if you actually do take care of your body, especially weight loss, you might decrease the need for blood pressure medicine. I've had patients who were actually hypertensive, and once they decrease their weight, they no longer need blood pressure medication. Okay? تمام. هلا وهذا what we talked about in a minute زي ما حكينا لكم على ال 140 على 90 والارقام اللي حكينا عنها. اوكي هلا شو ال initial choice what are the medications to use for blood pressure control؟ شو هم ال first line therapy؟ thiazide diuretics الشباب المبسوطة. What do you think؟ مش عارفين والله. Alright. So thiazide شو كمان؟ S or ARB or calcium channel blockers. هدول هم ال three choices as first line. اوكي هلا غير ال first line therapy هدول usually if I have a patient who has a blood pressure above 140/90 I'm going to start a medication. Thiazide would be my first choice if the patient is an African American. But otherwise, I'd probably go ASARB. هلا, if my blood pressure is too high, meaning he has severe hypertension, then I'm probably going to start with 2 medicine from the start. So it's better to start 2 medications at low or average dosing than to use 1 medicine at high dose. لأنه الدوز response بيقل as you go higher with side effects تزداد. Okay, so that's the second thing. So 2 rather than 1, especially in severe hypertension. هلا, again what to know about medicines. Thiazide diuretics very useful, لكن ممكن تعمل electrolyte disturbances, ممكن تأثر على الكدنيز if he are elderly أو dehydrated. ACE inhibitors or ARBs are excellent. They improve also the pumping function of the heart, but they might cause hyperkalemia or kidney insufficiency. ACE inhibitors might also cause cough. You should avoid both in pregnancy and young females. Calcium channel blockers, 2 types, dihydropyridines and non-dihydropyridine. Non-dihydropyridine also lowers the heart rate, so can cause bradycardia. These can cause reflex tachycardia, dihydropyridines, but very useful. Can cause also ankle swelling. هلا thiazide loop diuretics are strong diuretics, weaker blood pressure medicines. Potassium sparing are useful to combine with other diuretics to prevent hypokalemia. Beta blockers are very useful if you have coronary artery disease or if you're dealing with cocaine or amphetamines or pheochromocytoma. All right. Alpha blockers are useful for BPH and can also lower your blood pressure but can cause orthostatic hypotension, same as direct vasodilators. Alpha 1 agonists اللي هم مثل الكلونيدين أو الموكسينيدين useful for lowering blood pressure quickly but can cause what we call rebound hypertension if stopped abruptly. Okay. هلا threshold less than 130/80. I might accept a higher number بالblood pressure إذا كان patient elderly, sick, orthostatic. You can sometimes accept a higher number rather than your patient falling down or creating a problem. هلا hypertension and co-morbidities. Number 1, HFrEF, heart failure with reduced ejection fraction. هدول patients we know and one of the biggest parts of their treatment is being on an ACE, ARB or ARNI, which can help with blood pressure, so they should be on it. You should avoid calcium channel blockers that have a negative inotropic activity مثل الفيراباميل والدلزم. طيب سؤال سألته للمجموعة اللي قبلها. Why is verapamil or dilsem contraindicated بالheart failure patient while beta blockers, which are also negative inotropic agents, are indicated in heart failure?
Beta blockers يمنع remodeling للهارت يصير له hypertrophied.
صح. So البيتا blockers more than that. So beta blockers you don't necessarily want to use it in acute stage, but in chronic it helps. ليش؟ It upregulates your beta receptors. It also decreases arrhythmia, which is most common cause of death with heart failure. Also kind of decreases oxygen consumption, which shifts your myosin chains to the adult form أكتر, makes it more efficient and better remodeling. So higher theory, برضو it has been proven by evidence base. Trials have shown us that when we give them beta blockers, they get better. So that's why we should give beta blockers for patients who have HFrEF. Okay. هلا طيب بدي اسالكم الHFpEF mainly we give diuretics to give symptom relief. والACE inhibitors والbeta blockers you can use them for blood pressure control but not necessarily for الHFpEF بذاته. All right. هلا نيجي للspecific symptoms. إذا عندي stable ischemic heart disease, stable angina. So again, the problem is demand supply mismatch. So beta blockers can help reduce the demand. So it's very useful to use in blood pressure control in patients who have stable ischemic heart disease, in addition to ACE inhibitor. But probably I will go with beta blockers and ACE rather than beta blockers with calcium channel blocker as to start with. If he continues to have angina, a calcium channel blocker can be helpful لأن it vasodilates, reduces afterload, increases the blood flow. So برضه it's useful for stable ischemic heart disease. One thing I want to bring your attention towards is atenolol. You may increase the risk of stroke, so we usually shy away from using it nowadays. New studies that shows that. Okay, chronic kidney disease والproteinuria والalbuminuria increases the importance of being on an ASR لأنه they help with reducing برضه الproteinuria or reducing the kidney dysfunction, unless few people might do the other way, might have worsening. At that point you will stop it and switch them to something else. هلا yes. They help it. Okay, good question. Good question. So overall, ACE inhibitors and ARBs are actually beneficial. في minor percentage of patients will have a paradoxical effect ويصير عندهم worsening بالGFR وhyperkalemia. This is not the common approach. المعظم بتحسن. فأنت you cannot يعني ما بتحرمهم من الفائدة من الخوف من هاي lower percentage. What we do is we give them and we follow up. So إذا صار في significant increase بالcreatinine or worsening of GFR أو hyperkalemia, then those are the ones that you stop. And those are the ones that you should suspect برضه renovascular disorder. Okay. Otherwise, is a very minimal creatinine increase is fine. لأنه overall the function gets better with time they would do better. Okay, so that's a good question. هلا بالنسبة للintracranial hemorrhage. بالنسبة للintracranial hemorrhage أول شيء acute less than 6 hours بدك تشوف الإشي التالي. هلا you don't want it to be too high which will blood pressure which will increase the hemorrhage. والرقم 220. So if your blood pressure systolic is above 220, then I should lower the blood pressure a little bit. But I should never ever drop it to lower than 140. I actually should keep it ما بين 150 ل 220. So above 220 مش منيح, less than 140 مش منيح. In between. Okay? هلا هذا بالبليد قبل شوي. بالستروك بالacute ischemic stroke في عندي two types. في عندي acute less than 72 hours والchronic or subacute مش chronic subacute after 72 hours. بالacute السؤال انه if they come too early يعني اقل من 4 ساعات and they're still in the golden window where I'm going to treat the stroke with thrombolytics, then I need to look at the blood pressure. إذا the blood pressure is too high والرقم 180 185 على 110 صح؟ Yeah. 185 على 110 that is when above it is contraindicated. I cannot give him thrombolytics. So I'm going to need to treat the blood pressure, lower it لتحت ال 185 على 110 بعدين بعطيهم thrombolytic. هلا if they're not a candidate for thrombolytic الرقم 220. If it's above 220 I might lower it just a little bit 15%. Otherwise I'll leave it. Okay, so you got it? had بالacute stroke. هلا after 72 hours بالsubacute stroke بيعتمد is he already on blood pressure medicines ولا لا. If he's already on blood pressure medicine I'll keep him on it. If he's not بشوف blood pressure is if too high meaning above 140 over 90 I'll give it. If not I'll leave it. diabetes, ACE and ARB are useful, and again they help with proteinuria or albuminuria. AFib, ARBs have been seen to decrease recurrence of AF. With aortic regurg, we do not like to give beta blockers. Why we don't want to give beta blockers with aortic regurg?
Beta blockers بيزيد من مدة الدايستولي.
بالضبط. So aortic regurg is in your diastole. So when you slow down the heart, you prolong your diastole, you increase the regurg. All right, so this is where I'm going to stop for today. أي سؤال؟